text before I had a chance to hit record. Oh, I got to touch my own wife. That's weird. She asked me if I'm recording. How would she even? That was strange. Okay.
She's probably heard it enough at this point.
That's what she basically just said. She's so accustomed to overhearing you guys telling me to start recording. That's I guess I'm predictable. All right. I think we ended out on yes, the appendix. So the testicle has an appendix, believe it or not. And so what that is, and I quickly just drew a little, and I wish I'd done more of my own drawings rather than depend on other people's drawings. I just feel better with it. But an appendix testis and an appendix epididymis both exist. Probably every man has them. We don't always see them though. But what they are is they are Wolffian duct remnants, and so what you'll actually see is off the testicle, always off the top, like just a little knob coming off the testicle, or you might see it coming off of the, draw that one a little bit bigger. This looks like a deformed snail all of a sudden, but appendix, testis, epididymis. Let's see, testis and epididymis. My little snail creature. Of course, well, let's just quickly. So obviously the round part is the testicle, epididymis, head, body, and tail. And just as reminders there. And so off the head, and this is just kind of a quick review. We're going to have really the reedy testis in this kind of area. And of course, that is sitting inside of the mediastinum. Mediastinum, of course, is a part of or an invagination of the tunica albuginea, and then there's septa going from the mediastinum all the way out to the tunica albuginea, which is this all the way out here. What's called TA. And so it's septa. Each one of these is a lobule. Each one of those has a seminiferous, at least one seminiferous tubule, if not two or three. And the seminiferous tubules, let's go ahead and just draw a seminiferous tubule. It's going to be like all that. That's where sperm are created. Spermatogenesis happens inside of those seminiferous tubules. And then there's little cells all around, interstitial cells, the cells of Leydig, and that is what what creates testosterone. Those are the cells of Leydig. So of course, let's see, this all drains into the reedy testis here, and then there's afferent tubules coming from the reedy testis into basically the head of the epididymis, and then eventually this turns into a crazy long, squirrely tube. And at the end, it goes off in that direction. We'll give it a slight, I'll probably regret doing this, but we'll give it some, a little bit too big there, that's all right. So this becomes a vas deferens. Or it's a straight vas deferens, a convoluted vas deferens, but in any case, once it leaves there. So sperm, they created here in the testicle, travels to the reedy testis, travels to the epididymis, and then upon ejaculation travels through the vas deferens. Okay. high rate of speed. That's when they all put up their arms, go wee. Anyway, so let's come back. Appendix testis, appendix epididymis. They are both Wolffian. Is it? It's actually one L, two I's. I don't know what Wolffian duct remnants. Wolffian duct remnants. So I've got a couple of pictures and I've got a story. I hope I haven't already told you this story. I had this feeling that I kind of gave you a real quick lowdown of the story, and I shouldn't have done that if I did. Testicular artery and differential artery and cremasteric artery. I had to put an ER in there just before class. I misspelled it. There's the testicular artery. That's the main artery. And of course, we know it comes from the aorta all the way up near the renal arteries, below just a centimeter or two below the renal arteries. So they come up, they come from very high and travel all the way down. When I say main, most of the blood supply to the testicle itself is fed by the testicular artery. There are a lot of anastomoses. So actually, if one of these arteries does go bad, the other arteries can feed it, and that's good. The only problem is that when you have torsion and the testicle twists, it's twisting all the arteries at the same time. So having redundancy doesn't help all that much when all the arteries are twisted at the same time. The deferential artery, deferential artery is a branch of the vesicular artery. Let's see. Branch of vesicular artery. Branch of vesicular artery. Vesicular. That's actually you could just call this the bladder artery. So when we hear the term vesicle, we're oftentimes talking about the bladder. So the deferential artery is a branch of the vesicular artery. It feeds, for the most part, the epididymis and vas deferens. The cremasteric artery, that's the cremasteric muscle. I was having trouble spelling that the other day because, like an idiot, I didn't write it down. And should never do that. Cremasteric muscle is fed by the cremasteric artery. This artery feeds peritesticular tissues in general. So the muscle, the scrotum. I want to add another muscle in there too. And this comes from, you probably saw in the book, and honestly I had to look this one up because sometimes things just don't make sense. It is a branch of inferior epigastric artery. Epigastric. Gastric's your stomach. The epigastrium is this region high in your abdomen, but just below your chest. That's the epigastrium. How could this be a branch of an inferior epigastric artery? That doesn't make any sense unless it's similar to the testicular artery and it's somehow traveled all the way down. Well, what it actually means is this. Let me just grab a red color here. There's actually a superior epigastric artery, and it travels from the epigastrium. So if this, let me go back to There's my my sternum, my rib cage. My oh, here I got a six pack here. I do have one. It's just buried underneath some insulating tissues. So let's go back to red. Okay, so the superior, and this is just extra. It's just something that bothered me, so I had to figure it out for my own. The superior epigastric artery kind of travels along the abdominal wall and down. The inferior comes up and, well, and not to mention down into the testicles, but a branch of the inferior epigastric artery goes down. That's the cremasteric artery. But this guy comes up, and the anastomose, somewhere in the middle. And so that's why they could get away with calling this an epigastric artery, because it's like one lane. It's one road of an artery. It just happens to be connected both up high and down low. So anyway, like I said, not a big deal for us to know that. Just bothered me. The pampiniform plexus. Oh, I looked up pampiniform. It is not. I thought it might mean net-like. There's actually another word that means net-like. Shoot, I'll remember that at another time. Pampiniform is actually vine-like. Vine-like is what pampiniform means. But anyway, veins form this pampiniform plexus, and the most famous one is in the scrotum, or in leaving the scrotum. Go to image for intratesticular arteries. Oh yeah. Here, I'll just mention one little thing since it's right here, and I don't want to miss it. This is just a reminder to myself. And then arterial resistance. The mean resistive index is 0.62, is about the same as in our brains.
I'm sorry, Kurt, can you repeat that? The veins form what?
The veins form a pampiniform plexus. I'm going to show you a picture of that in just a second.
Okay.
Am I the only one? Arterial resistance in the testicle is the same as in the brain? No? Nobody? Okay, all right. I thought that was hysterical. I was like, well, yeah, no kidding. Okay, so let me zoom in, a little zoom. All right. So, our gonadal artery, in this case, testicular artery, testicular art is there. They both come off. It's not quite like that, not in the same, they're off the sides. They don't have a common trunk, but that's all right, no big deal. Goes all the way down. The differential artery, what did we say? Oh gosh, because I'll be honest with you, I don't have this memorized, this part here. Part of the vesicular artery, which is also a part of the internal iliac artery. And then the cremasteric artery is also a branch of the inferior. Actually, this is a poor picture. It's really not showing that. It's kind of this is a real basic picture. That's okay. Honestly, when it comes to these arteries, you need to know the testicular artery comes from up high, and you need to know that there's a couple of other arteries that do feed the tissues around the testicle, and there are anastomoses feeding all three. So if one goes bad, the other two can feed it. The problem is, like I said, though, testicle twists, they all twist together. Here's our pampiniform plexus, and so I guess it is kind of vine-like, kind of traveling up, and has all sorts of little branches coming around, and it's probably good that that I'm drawing in on this side too, because men have a problem 98% of the problem is on the left side as well, and it's called a varicocele. I'll just write it down. Varicocele, and that's well, it's a varicose vein of the pampiniform plexus. But anyway, pampiniform plexus drains both testicles, scrotum, everything, the whole inguinal canal area, and comes up. And they, oh boy, they show them. I'm sure there's probably a little branch that goes into the internal iliac, but for the most part, they, just like the testicular artery, this is the testicular vein. Now, on the right side, the testicular vein goes directly into the IVC. On the left side, and this is always a test question, the testicular vein does not go into the IVC. It goes into the renal vein. Well, of course, because there's a spine here in the way, and there's an aorta sitting over here. So there's a lot of stuff, and if this vein were to cross over, it has a lot of problems. So instead it's going straight up to the renal vein. Now that causes some problems, and it's one of the reasons why men get varicoceles on the left 98% of the time is because of this whole problem here. We'll talk about that in a little bit. All right, now when it comes to, let's go back to arterial supply, and obviously this is the testicle and the spermatic cord coming down. And the biggest one, as you could imagine, is that's the testicular artery. Testicular artery. And let's see. Oh, this one has got to be, I don't even have to look at my notes. The deferential artery, although, where did I see? Oh, no, it was somewhere else. Deferential. And then I'm going to put in brackets vas deferens. Because I've noticed, while doing a little bit of research, that some places call it deferential artery, and others just say the artery, the vas deferens, or the vas deferent artery. So same thing. And then this would be the cremasteric artery from the cremasteric muscle. Oh, okay. So, and there's I mean, like this guy here. I'm not even going to write it in. It was like the superior epididymal. I said, I'm trying to say epigastric. I knew that was wrong. It's superior epididymal artery and all that. We don't. Let's not hurt ourselves with that stuff. We will mention that there is a mediastinal artery, and about 50%. I'm just gonna, let's see, I'm gonna put 50% of men. So half the men have this, half of them don't. It really doesn't matter. This is the mediastinal artery. And oh, what direction is that traveling? I'm going to put arrows for the direction of travel. Let's, well, let me do that after, because I want to do it in a different color. This is going around the outside. We could call it an arcuate, but we're not going to. We're going to call it a capsular artery. And that's going around under the capsule, of course. Then, if you think of different forces, centripetal, centrifugal, this is a central pedal artery. Center. Centripetal. You know what? I'm sorry, that's with a T. Centripetal artery. And then we have this, let's see, there's an arrow pointing here. That's the recurrent? Yes, recurrent. Rami or Rami, which is artery. Let's see, that's all the ones I want to do? It is. Let me put another color in here. And this is worth mentioning because it can get confusing. Let's see, blood flow obviously is coming, let's just start all the way up here. Blood flow is coming down. Oh, can't see it. Okay, it's going this way. And then here, some of it continues to go this way. And then the mediastinal artery goes in this direction. And then out here, the capsular arteries, they could really be going either direction, just depending on where you are in the testicle, whether you're superior, inferior, or middle. And then the centripetal arteries are going this way. And the recurrent Rami arteries, I'm just going to draw it up here because I'm running out of room, are going that way. So when you do a testicular ultrasound and you put color on, but when you do ultrasounds on any other organ, you know, the arteries are going this way, the veins are going that way, or you know, vice versa, whatever you're looking at. It's always kind of, the arteries are all going in the same direction, more or less. When we do a testicular ultrasound, you could have one traveling anterior to posterior right next to another one going posterior to anterior. So it gets a little confusing. Not the biggest deal in the world, not the biggest point in the world, but just a point I wanted to make. Because honestly, it's when I was a tech and not an instructor, it always struck me as odd. Like, why are these arteries going in the opposite direction? Because I really didn't remember from when I was in school. I didn't remember the anatomy of the arteries that well. Tisk. Throw that page aside. Okay, cool. Protocol. So that's basic anatomy. We can go over, I know yesterday was probably a little confusing. If you guys want me to go over anything from yesterday, I am more than happy to. Let's see, I think I need my black color back, and it needs to be a little bit bigger. Handwriting's bigger here. Okay, so protocol, my protocol. I don't agree with the book. The book, and I right off the bat, I was like, nope, I'm not going to listen to your book. The reason being is because the book started superior to the testicles. It was looking really at the inguinal canal. Here's the thing. If this is an emergency ultrasound, and some testicular ultrasounds are emergencies, some are not. But it's just a good idea just to be in the habit of going directly to the emergent properties. If it's an emergency, there's really no other reason for an emergency ultrasound, probably trauma, but I would say trauma, but far more emergent is torsion. Your patients who have torsion are going to be in unbelievable pain unless they've been well drugged, well medicated. And the only thing the doctor wants to truly know is there blood flow in both testicles? And by going straight to that part of the exam, you could answer that question immediately. You could pick up the phone, call either the radiologist or the ordering doctor, probably safer with the radiologist, it kind of depends where you work, and you say, there's no blood flow in the left testicle. And they say, okay, send them straight back, because they're going to go straight to surgery. Some doctors with a little bit of guts actually take the testicle and boop, twist it real fast. Hopefully they twist it the right direction, but they'll twist it back, and there's a moment of blinding pain, and then total release of all that pain. So I don't know if I was that patient, if I'd want that, or just go straight to surgery. The problem is every minute that goes by is a chance that you're not going to recover that testicle. Okay, so let's see. Patient prep. We'll discuss this more in lab. It's kind of, I could do this whole explanation thing, but and trust me, I'm not going to show you in lab either. At least I'm not going to show you a live demonstration, but I will show you in lab. Actually, we have a dummy. We have a phantom that we could use. So first image we take is the twins in grayscale. Take time at this moment to optimize your image because we want quality images here. So twins in grayscale, that's, basically you do a transverse picture. And there you go. That's your first picture. Your second image is the same thing, but you put a color box down. And you compare color between the two. So second image, twins in gray. We'll say twins in color. Once again, optimize Doppler. Gotta optimize it. So, in other words, if you come in and you see, let's see, some arteries radiating out like that, and maybe a little bit of artery here, and of course there's gonna be some artery in the scrotal sac and stuff. But then you come over here, maybe you see some arteries in the scrotal sac, but you see nothing, or you see very little on this side. That's an indication, like, whoa, whoa, that's wow, whoa. I guess whoa is with an H. Anyway, this is what we're paying attention for in that second image. Third image, right. Sorry, hold on. My list is slightly different on the page than it is here. My twos, I gotta hide all my numbers now because my numbers are off by 1. It's messing me up. Okay, so once we've taken our twins, grayscale, then color. Oh, by the way, grayscale on a if it's an acute torsion, grayscale is going to look normal, or can look normal. Okay, then I'm assuming where everything's fine so far, I'm going to go to the right, and I'm going to do a sagittal, like right down a sagittal ML midline, and I'm going to get a length image. And then on the right side again, I'm going to do a transverse mid, as in mid pole, not the top, not the bottom, not in the mid, and I'm going to get a width. I don't particularly care where you get your height. Good Lord. We'll just call it AP. AP doesn't matter, length or width, I don't care, but you are going to have let's say 4 centimeters length times 3.5 times 3.4. They're usually pretty close, because it's mostly round, unless you're pushing down really hard, then it becomes rather oblong. Length, width, height, or something like that. Or it could be length, height, width. Honestly, I don't care about these two numbers. I always put length up front, though. I personally don't care about the second two numbers. And if anyone else does, then you do what they say. Sagittal. Okay. Now I did this. I went from sagittal, and you could do this on the thyroid too. You could do this on an ovary. You could do this on a number of organs. Sag, trans, because I wanted either one picture, maybe if you do a split screen, maybe, or at least two pictures in a row. All your measurements are close. Close meaning when the radiologist is going through these pictures, he or she doesn't have to find the length here, and then 10 pictures later they find the width and the height. That's just doing your doctor your favor, your reading physician a favor. Okay, so we do our sagittal or transverse. Then we go. Let's see. Did I stick with transverse? No, I went back to sagittal. Oh man. So right sagittal, lateral to medial. Now this is probably what I'm writing down on my screen too. Right sagittal, lateral, dash medial. And that way I don't have to keep changing it every single time I take a picture. So we go, let's say that's 4 to 5 images. Right sagittal. And then we're going to go from yeah, I did screw something up on my notes. Don't worry about it. And then right trans, superior to inferior, and that could be about 4 to 5 images. And you could just scan on through because you've already taken your measurements. You don't have to stop and measure at any point. And then we're going to go to right epi head. Now, can you take that at the same time as you take your sagittal image? Yes, you can. But for now, we're doing it separately. Right epi head, we're going to measure length and height, I think. And then, oh, I'm sorry, that was sagittal. And then right epi head width. Whoops, that was trans. And then I'm going to try to find right epi body, tail, and sagittal. So having wrote this out and realizing that I did something slightly wrong in my notes here, I kind of got you going sagittal, trans, sagittal. And if that doesn't make sense to you, then fine. Just avoid that. I am going to add a 10 here because I missed a number. Right inguinal canal, and that, you know what, let's just do, we'll do a sagittal and trans with Valsalva. Valsalva, that's that motion where you go, take a breath in and you squeeze and you push down. I see you guys all smiling and stuff. I know you got little texting going on back and forth. I should run to your house and grab your phones. And Anyway, so right inguinal canal, sagittal and transverse with Valsalva. You're going to push, you're going to have to ask the patient to push down. You're looking for two things here. And if there's no indication for it, you might skip the Valsalva, but I just do it anyway. You're looking for varicocele, that blood flow, those veins will get larger as time goes, as a Valsalva. And you're also going to look for any evidence of a hernia. Okay, you've done the right. You start over, do the left side. Get your measurements. Yeah, that's right. Skin. Oh, let's see. You know what? I did have a little note. Let's just add with this little note here so we're being good. All right. While you're doing this, you are paying attention to thin skin thickness. Obviously, cysts or solids. Any kind of neoplasm, cysts or solids, any free fluid inside the scrotum, and of course dilated veins. I already mentioned the varicocele. So varicocele. And I'm going to add one thing. I was just thinking, when you do a Doppler, if you do a spectral Doppler of both artery and veins, if you do both of those, then you get to charge more. So your doctor, your location, your hospital might say, every time I want to see arteries and veins. Well, they could pretend that it's all about due diligence and making sure everyone has a blood supply. They could pretend that, but what it really boils down to, that's an extra Doppler charge. So, but it has to be arteries and veins. If you only do arteries, it's not a full Doppler, and they can't bill. They can't bill for it. All right. So, I did not even include a decrease in size on my notes here. I'm just going to say decrease in size could just simply be a decrease in gonadal stimulating hormone from a pituitary gland. That pituitary handles all of your glands. It's the master control, so it could be simply that. Cryptorchidism, we're going to talk about that anyway, and that's a undescended testicle, and that will be smaller probably because it's being crushed inside of the inguinal canal. Missed torsion. I wrote WTF with that one because how do you miss a torsion? Those are unbelievably painful. Although actually I do have one example that I know of. Post-surgical, well, actually the example I know is post-surgical. Chronic orchitis, so chronic infections can make the testicles a little bit smaller. And then I just wrote down one last one is, the guy's old. They get smaller. I mean, hate to say it, guys, it's gonna happen to you. Trust me. Anyway, let's see, we have 42. Let's go through just a couple of these and then I'll let you guys take a break. Torsion, so we mentioned that. That is twisting on the pedicle. Very, very painful. And that's torsion, whether it's an ovary or testicle. They're unbelievably painful, or anything that's torsed. There's a few organs that can become torsed, and you don't get a blood supply. That's painful. The Doppler I wrote is diagnostic. So look at these two. The grayscale on these two testicles is pretty much identical. We don't see any differences here of note. But there's no blood flow inside of this testicle where there is in this. So always, always, always do your Doppler on these. Let's see. All right, I seem to be a little bit out of order on my notes, but I'll just finish up this, and then I have to look at my notes and figure that out. But let me just finish this one. Oh, how do I finish this up? I don't have torsion. There it is. Those with torsion probably have a deformity. It's not a big deformity. It's just a little thing that you would never know you have, and it's called the bell clapper deformity. So let's see, when I drew this testicle before that, let's see, I'll draw a little epididymis on it, right there. There is a potential space. There's supposed to be a potential space kind of right here. I'll fill that in. This is where if fluid is supposed to get in there, that's where it all gets. The testicle should be attached to the posterior wall, and just like the liver, just like the spleen, it has a bare area in the back that should, and I don't know exactly how to draw it, but that's basically where it's, so this is where our is supposed to be. Now, some people just simply have and except this time we're going to have it whoops. So what I'm filling in here is now the new potential space. In other words, there's really no bare area holding the testicle kind of more or less in place, more or less. They call it the bell clapper because a bell clapper, let's see if we had a little, and then there's as you swing this bell around, this guy is free to move backwards and forwards. The analogy is that's the testicle. This would be the spermatic cord, and this is the scrotum. And so if he's able to move in every direction, then he's able to twist around and cause a lot of problems. So orchiopexy is the surgery to staple it down. This makes me sick. Orchiopexy, it's the same. It's called the same surgery, whether you're simply fixing a bell clapper deformity or whether the doctor has had to remove and slide a testicle from the inguinal canal or from the abdomen into the scrotum and then staple it down. I'm sorry, every time I say that, I throw up a little bit in my mouth. Torsion, sudden onset of pain, nausea, vomiting, and wishing you were dead. Okay. Loss of cremasteric reflex. So torsion, loss of cremasteric reflex. That reflex is when on a man, if you take a finger or fingernail and kind of scratch the inner thigh, testicle actually moves up. That is a reflex, just kind of just the way the nerves from the thigh and the premastic nerve interact with each other. And so that's one way of telling. The doctor will take a, maybe a pen cap or something and just scratch it along the inner thigh. And if the testicle does not move, then that is evidence of torsion. And then last for right now, whirlpool sign, or also called the knot sign. And that is, like I've drawn over here. And you can see it's in grayscale, and then if you put color on, maybe if the color's still going through a little bit. But as you're scanning, let's say you go transverse on the inguinal canal and you follow the the spermatic cord, and as you're following, it's kind of going, and then suddenly, whoop, on your screen, it does a little circle. That's another evidence of torsion. All right. And subheading, torsion of the appendix. But you know what? That comes with a fun and entertaining story, so we will hit that. All right, guys. So I decided just to, sometimes it's easier to have a dozen or so pictures in front of us rather than just the one or two that I choose. And I realized I didn't have any normal images of the appendix testis or appendix epididymis, and so I grabbed some. Ooh, there's a torsion of one. That's not good. So, but here's a very typical. This one's surrounded by fluid, so this person has a hydrocele. That's not normal, but this appendix testis is normal. That's completely normal. And here's a appendix epididymal appendix. So that too is normal. And that amount of fluid here, we call that physiologic when the fluid is of normal size. And more appendix epididymis, because that's the epididymis here, that's the appendix, there's the testicle, appendix testis here. So that's what they normally look like. This one is too large, and got that. And I was just looking at, I just wanted to grab some normal, oh, that guy's coming off. Normal testicle images. There's a great normal image. The transducer was too small. So, big guy there, but so this person had to do this is a split screen, 2 different images, and they just married the images up carefully. So that's what they did there. You've seen some of these pictures already. And not always, like in this image and on this image, and these are, like I'm pointing out long images, you don't always see the mediastinum because it's not always in the picture, of course, but here's a mediastinum there. And then on transverse pictures, there's a mediastinum along the side here. Usually, so let's see, there's that picture again. Ooh, polyorganism. This guy's got an extra testicle there. This person has very mild ectasia of the reedy testis. So normally we don't see these tubules here, but they're there, and that's completely fine. It's not going to hurt the person. This person's got pretty dramatic ectasia, and this person's got pretty dramatic ectasia on the reedy testis with a cyst in there as well. So anyway, oh, and I was gonna. So this picture is as difficult as this is to see, and I apologize, but we can't. I don't like the way they do things now. I don't want to go to the site either, but testicle travels down. And actually, I read something interesting, and it is pronounced gubernaculum, which I think is hysterical. But the gubernaculum, it does its pulling on the testicle and on the ovary by staying still, which is interesting. The rest of the body is growing and growing and growing, and what the gubernaculum does is it's attached. In the case of a man, it's attached to the scrotum, going through the inguinal canal. And we're talking, of course, about a tiny, tiny little baby, a fetus, when this is first happening. And then as the fetus grows, the gubernaculum just stays still. And so the testicle is forced to come down with it. So the gubernaculum isn't really actively pulling, it's actively staying still, which is kind of interesting. But I also chose this picture here because it shows that testicle really is supposed to be attached. Now it's attached to loose skin, so it's not fixed that tightly, of course, but it's supposed to be somewhat attached. Another image of that. But okay, so back to the appendix testis we mentioned in just general anatomy. It can have a tosin. See, I know how to spell sometimes. Torsion of the appendix testis. So that, I don't know if you guys just wave me off if I've already told you this story, but I literally, about 16 years later, I still have pain, physical pain from this incident. And what it was is I had a patient with a torsed appendix testis. I was working the weekend. I did not have a radiologist. Didn't even have one to contact, which was really unusual. I guess if it was an absolute emergency, I could have contacted someone, but it was just an unusual situation when I was really on my own. And so when you write reports, those reports are considered tech reports, not radiology reports, but they still go in. You have to be careful what you write. And I wrote question or possible torsion of the appendix testis, and the radiologist who came back in on Monday to read that exam absolutely she flipped out. She was so angry with me. She was spitting fire because that patient could have gone to surgery on my recommendation. And I'm a technologist. That should never, ever, ever happen. So I understand why she was angry, but on the other hand, I write reports all the time. It's just that those reports usually go to a referee, the radiologist, or a judge, really, who makes their judgment call, and they either agree with you or they don't. It doesn't really matter. It's up to them. So she was furious with me, and then they brought him back down, and he was still in a lot of pain, but a little bit less pain. Well, yeah, torsion only hurts for so long; it eventually goes away. But what I found was something very similar to what we have over here on the left is a larger than normal appendix testis and no blood flow inside of it. And I really tried, and I put it on power Doppler, which you can see on the second one, it's got on power Doppler. And I didn't see anything. And eventually I turned up my gain until I could see a little standing wave. You got to be careful. That's not blood flow. And the evidence that it's not blood flow is that the technologist put spectral on this little standing wave. And when I say standing wave, I mean like there's like a little piece of color was sitting in there. But when they put spectral on it, this isn't flow, this is noise. That's noise on either side of the baseline. And so that's what I found when I did it. I'm like, oh, okay, so wow, there is no flow in this. I think they have a torsion appendix testis. And So they brought him back down, and she was really, she told me she didn't want me scanning him, and someone with experience was gonna scan him. And my experienced tech with 15 years experience turned around, looked at the radiologist, and after finding this, and said, "There's flow." And the radiologist gave me a snotty look and walked out of the room. And I was dumbfounded. I was furious. I was furious at my fellow tech because they just threw me under the bus. I mean, obviously they have to do what's right for the patient, but they were just wrong. So I went and got my lunch. And by the way, this is my last day of work anyway. I went and got my lunch. I had peas in my lunch, and so I took it into the ultrasound room. And I put some gel on top of the pea, put my transducer down, and I turned up the gain on power Doppler until I got myself a nice little standing wave of so-called sound inside of a pea. And then I spectraled it, and the spectral looked just like this. And I sent that to the radiologist with a little note saying, "Wow, this is really amazing. I found blood flow in my lunch." But obviously it was my last day anyway. But so I don't care what she thought of it. I was already gone. But the moral of the story is I did put myself in jeopardy by writing a note that went straight to the surgeon. Surgeon could have made a decision on that, and I would have been fired probably. But the other thing is, the other note is, doctors aren't always right. They're often right. They're usually right, but not always. And and the pain is right in my epigastrium. I've had reflux. I've had stress-related reflux ever since that day because I was so stressed out by this. So now whenever I get stressed out, it hurts like hell. Anyway, I am recording. Okay. I always wondered what happened when she got that note. She came tearing out of there looking for me to fire me, and found out that I was already gone. But oh well. So let's see, rupture. I got a picture over here of a rupture. It is just god awful. Who skipped any other pictures? No. Oh God, and there's loads of videos of young men being stupid, usually skateboarders, oftentimes called a straddle injury. Good Lord, Kurt. All right, straddle injury is, and oftentimes we see patients for that, and you just pray to God this is not what you find, because I'm feeling nauseous just looking at that. But we're going to look at the tunica albuginea. Is it intact? Is it intact? We don't know. Is there a hematoma inside or out? So blood, active bleeding inside the testicle or outside, perhaps in the scrotum. There's hematocele. The difference between a hematoma and hematocele, this is bleeding into the scrotal sac. So this person seems to have their tunica albuginea is not intact. It has been blown apart. There's a hematocele. There's blood going into the space. I can't really identify a hematoma per se, but a hematoma and a hematocele are pretty closely related, so I guess you could call that. Rupture is so usually a straddle injury, sports injury, automotive. can't really imagine the doctor doing it by accident in surgery, but I think that was in the book too. So here's the number. This is probably, let's see, I'm going to say, this is just me, but I'm going to say number one reason for for seeing a patient in pain, and who actually has something, it's not just being a baby, is the epididymitis and orchitis, or epididymo-orchitis, if you put the two words together. This usually starts in the tail, which it surprised me when I read that, but I'm like, well, that makes sense because most of these are coming from bacterial infection. Well, that's going to run backwards through the vas deferens, backwards, and of course it's going to, from the vas deferens, it's going to meet the tail first. So it starts at the tail. My experience is it's in the head, but it makes sense to say that it starts in the tail. So I'll agree with that. Starts in the tail. 20 to 40% of epididymo-orchitis. In other words, that means both the epididymis and the testicle. Now this person seems to have, just by color alone, epididymitis. You could see there's increased color flow in the epididymis, but the testicle itself seems pretty normal. A little bit of a hydrocele around the outside that could be reactionary to the epididymitis. So this is our hyperemia. Of course, we're going to Doppler. Oh, and you know what? The one thing I didn't do when we were taking a quick break is figure out what I did with my, okay, here's that page. I guess we're okay. All right. So with epididymitis and some other infections, we could have scrotal wall thickening. This person does not appear to have scrotal wall thickening. That appears to be normal thickness, and you'll see it yourself. If there's thickening of the scrotal wall, it'll just look. I guess it kind of looks adenomous. Hydrocele can form, and this person does have a hydrocele. You can see over here. And one of the things that they're going to come in with is not always testicular pain, but sometimes just low abdomen pain. And that low abdomen pain could be because it's more of a epididymitis, maybe vas deferens are also inflamed. Maybe it's referred pain, so the pain is actually in the scrotum, but they feel it in the abdomen. Now, the reasons to get this are varied. That's sexually active and single, perhaps somewhat promiscuous. Then could be, let's see, chlamydia. Those Y's always confuse me. Chlamydia or gonorrhea. Is there two N's? No, anyways. Chlamydia or gonorrhea. But plenty of people who don't have chlamydia or gonorrhea are also coming in. They're either younger or older. They're less sexually active. These guys are probably more likely to have E. coli, that bacteria that causes problems for everyone, everywhere. E. coli and Proteus, which sounds like some kind of evil god, Proteus. E. coli is that's gut bacteria, and Proteus is soil. What was it? Oh, I guess I didn't leave myself a lot of room here. And I could attest to this post-traumatic. So, and this would be non-bacterial, kind of almost like a sterile infection, which I know sounds like a oxymoron, but they do sometimes use the term sterile infections. So I could tell you that when I was in college, and this is quite a few years ago, I was in martial arts. I was pretty decent, and I was fighting a guy who was 6'3", and we were supposed to be holding our punches, and I had my foot up by his ear, and he decided to do a side kick, and he dropped me. I was on the ground screaming for about 10, 15 minutes, and eventually made it back to the dorm. And then 2 weeks later, I was in the hospital, and it was basically a post-traumatic epididymitis. Of course, that was 30 years ago, so no ultrasound back then. It was just more guesswork at that point. But anyway, so I could attest that is a thing, because I've had people tell me that they've never heard of post-traumatic epididymitis, and I always tell them, yes, it can be. So epididymitis, not the post-traumatic kind, but the bacterial kind, may progress to abscess, and that's very bad news. So at that point, you're losing a testicle, losing, you might maybe even your scrotum. I mean, abscesses are kind of bad things. Let's see. Okay, yeah, I do have a couple of good, decent images here. Up top here, we've got the normal right testis and epihead. So testicle here, and then epididymis head here, kind of a usually triangular, triangle laying outside in the sagittal. Normal blood flow, normal echogenicity. And then on the opposite side, the left testy, the epididymis doesn't look too bad, but the testicle itself is definitely increased in blood flow. So it's hyperemic. That's a lie. Hyperemic. And then I just chose one out of hundreds of abscess pictures. An abscess is an abscess. They kind of look the same all over the body, but I figured I'd choose that one because this is evidence that if they have an abscess, you won't even know what you're looking at. Hydroceles. Okay, yeah, hydrocele, that's pretty common. The gigantic ones aren't so common, but the smaller ones are. You could have congenital. And that is failure of process vaginalis to close. So, in other words, the peritoneal cavity kind of is supposed to pinch off. It goes into the scrotum, and then it's supposed to pinch off and tighten up and not allow any communication. If it fails to close, you know, that's a congenital hydrocele, because the abdominal cavity, I mean, you got all those organs in there. There's always going to be some fluid and the testicle being the lowest point, the fluid's going to make it into the scrotum. 6% of boys at delivery will have a hydrocele. I would say more than 6% have some fluid in their scrotum, but 6% have a congenital failure of the process vaginalis to close. I would say probably at birth, a lot more boys have some fluid in the scrotum, but only 1% of men have a patent process vaginalis. Number 2 is acquired. Let's see, hydrocele, and that could just simply be from infection. We just saw that with the epididymitis, orchitis. That infection causes a local fluid to leak out of the tissue into the space. Torsion. You could have high blood pressure inside of the veins in torsion that literally squeezes blood serum out of the vein and into the space. Cancers. Cancers can leak, they can bleed, and trauma can all cause hydroceles. And so this is a great picture because we're actually killing 2 birds with 1 stone. Actually 3 birds with 1 stone. Over here on this end, it's actually not a hydrocele, that's a good size spermatocele. So perhaps, and this person has, look at that, he has a little bit of 4 birds with 1 stone. He's got a little bit of ectasia of the reedy testis, just a little bit. A decent sized spermatocele. A hydrocele over here. And a hydrocele down there, and that little attachment there, that's the remnant gubernaculum remnant. That's an awesome picture for that reason. Where's my? Oh, there you go, all the way down there. Okay. With hydronephrosis, and hydrocele, hydronephrosis was a couple of chapters ago, you can sometimes see a little structure. I'm just going to go ahead and draw one in. Let's just kind of put it right here. Draw in a little scrotal pearl. Also known as a scrotal mouse, or more technically as a scrotal lith. And these guys are literally just a little round, movable. That's why they call them mouses, because they move, and pearls because they're little round inclusions, little pieces of calcium. Probably mostly calcium, probably other cholesterol crystals or whatever. And they could probably form after some kind of infectious event or perhaps a bleed, hematocele. And those are very common, and I needed that, and not at all painful. And here is one picture of a pearl right here. With a bit of a hydrocele around it. What is this picture? Oh, that's right. This one, I was just going through the internet, and this one really struck me. Look, when we have hydronephrosis, hydrocele, the testicles should be, now granted, the transducer can be held AP, it could be held sideways, which is going to change exactly how the testicle looks like it's hanging, floating, or whatever in there. But really, the testicle should be back here. This one's up here, like it's like floating. And it's, you know, it's attached a little bit through the spermatic cord here, but that's about it. That's the only thing holding it in place is spermatic cord, and also, I guess this is a transverse image, so, but still it should have been, you know, so if I did transverse, it would have been more round, but still it should be down there, not floating up to the top. So that makes me wonder if this person had a bell clapper deformity, or perhaps they've suffered trauma and they've torn the testicle away from the wall, like where it's supposed to be. Ooh, okay. Oh my God. Oh shoot, yeah, we're not gonna get through this today. Okay, that's all right. Sorry about that. Once you screw up, it's hard to unscrew it up. Okay. To know the difference between a spermatocele and epididymal cyst is probably, for the most part, impossible, unless you just go by location alone, because spermatoceles are oftentimes in the head. Where am I? Yeah. So usually in the head, and we see this every day. And men come in every day. They just noticed it. They were in the shower and they were washing up and they just noticed something there. Sometimes they just notice that they have an epididymis for the first time in 30 years. So this person's got a very small amount of fluid. In fact, I'm going to call this a physiologic amount of fluid. When it's that much, most doctors won't even call it. Some of them will, though, so it's up to them. Spermatoceles should have low-level echoes. And like when you put Doppler on them, they'll actually even move around. And those low-level echoes are probably like dead spermatozoa. Low-level echoes. Oops. Low-level echoes should be there. Epididymal cyst can be a little more, they could be up here as well, in which case you're never going to know the difference between an epididymal cyst. And this is truly a simple cyst, really. But these are, epididymal cysts are anywhere in epididymis, in other words, head, body, or tail. And these are basically just a simple cyst. You find these in the head every single day, not a big deal. Then we have tubular ectasia. Oh, we've already mentioned this. And I purposely grabbed a pretty mild case of tubular ectasia here. Remember, that's post-vasectomy. Post-vasectomy or obstruction of some kind. Sometimes we'll find cysts, as in spermatoceles, could have caused the obstruction, could have caused the ectasia, and possibly inflammation of efferent ducts could also possibly cause tubular ectasia. But we've talked about that a couple of times now. Let's keep moving. The varicoceles, these are important as well. Also known as, AKA, bag of worms. Fun, because that's what it feels like, because you have a bunch of enlarged veins. Bag of gummy worms, bag of worms, whatever you want. That's it's going to feel like, and perhaps even look like if they're large enough. Let's see what I have. Oh, okay, that's right. So varicocele are veins that are greater than 2 millimeters. And this is going to drive me crazy. 2 millimeters. They can be caused by incompetent, got an E in there, valves. Now, what does that mean? Next semester, you're going to be looking at a lot more of this, but our veins, say the veins traveling in this direction, our veins, most of them have little valves. The valves are designed so that when blood is pushed through, they can travel in one direction, but when the moment that the blood has stopped being pushed through and the blood tries to come back down, the valve shuts down and blood can't go backwards. So if you have incompetent valves in your veins, you will get varicoceles. Well, varicoceles in this case, varices like in the legs. When people have varicose veins, it's because of incompetent valves. Nutcracker. C-R. I was a couple letters ahead of myself. N-U-T-C-R-A-C-K-E-R. Nutcracker syndrome can also cause that. Now, I mentioned earlier, so I can do this without screwing up. I mentioned earlier that this is a problem. On the left side, the vein comes up to the renal vein. The testicular vein comes up to the renal vein. Remember what that renal vein does. In transverse, we have our aorta, we have our SMA, and then we have the renal vein that comes over and finds the IVC like that. A lot of times, the pressure between these two is pretty great, and that slows blood down from the renal, well, from the kidney, but also, now we know, not only from the kidney, but from the gonadal veins, either testicular or ovarian. So something like this could happen in women too, it's just that we don't see it because you're on the inside. So nutcracker syndrome, this is a cause for infertility. Very common for male infertility, it's because of varicose veins. Why? Because testicles are on the outside of the body for a reason. It's not just because we like to get kicked. They're on the outside because they need to stay cool. They want to stay cool, but now if they're surrounded by all these heavy veins and all this extra blood, they are going to warm up and cause at least one-sided infertility, or at least one testicle is going to have low fertility. A couple of kinds, primary, what do I have for primary and secondary? Primary is 15% of men have primary varicose veins, and of that, 98% is on the left side. So you can see that if 15% of men, all right, that's just the overall, 98% is on the left side. You can see that the Nutcracker syndrome is a huge deal. A lot of books will tell you that it's because of there's a 90-degree turn at the vessel turn, goes up and hits the renal vein at a 90-degree angle. That doesn't make any sense at all. The Nutcracker is the real reason for that. Secondary. Secondary. I didn't leave myself any room here. Just a few weeks ago, months ago, years ago, God, it's going on forever here. We were talking about cirrhosis of the liver and how the portal system can become backed up really badly. Now, this technically isn't part of the portal system, but cirrhosis or a mass, they say Nutcracker, they put Nutcracker into secondary. No, sorry, it's not. Or they've misidentified primary, but cirrhosis or a mass causing pressure or causing back pressure, so the blood's not able to get out because the mass is blocking it, or cirrhosis is causing all sorts of backups in the system. And then rarely, rarely ectatic veins, remember ectatic means enlarged veins, go all the way to reedy testis. In fact, I've never seen it. So all these veins they're coming from the reedy testis, so it actually makes sense that the varicocele could actually make its way all the way back into the testicle itself. Well, like I said, I don't think I've ever seen that happen. Valsalva plus Doppler. This is in the scrotum itself. Sometimes you see more evidence for varicocele up in the inguinal canal. In either case, you gotta look for it. Have the patient Valsalva. We could look at the blood flow kind of going backwards, and you could, or even without Doppler, you have Valsalva and then measure before and after a Valsalva to see what the size of the vessels are. So let's see, 2:48. Oh, golly! All right, we have another full day. I can't believe I didn't think this was going to take so long. Hernia, we'll stop after this one. Oh, wait a minute. Do I want to promise that? Hernia. That's an easy one. We'll at least get through that. Okay. Two kinds of hernias, and it's always, I got to read it because it always gets me backwards. The direct kind is more likely, and I would think the direct is the indirect, and the indirect is a direct. That's why it always confuses me. More likely adult men. This is from maybe heavy lifting, And these kinds generally don't go all the way into the scrotum. They will go into the inguinal canal, though. So they're not following necessarily the process vaginalis, but they're going along that same direction. And I've got a couple of images. And then the indirect is more likely children. They didn't do any heavy lifting. They just had a defect that allowed a bowel or whatever, a fat bowel omentum, or maybe just fluid to get into the scrotum. And so that was a defect in the process vaginalis. And over here, we have a nice image of an indirect. This happens to be a young child. Here's the testicle. There, I don't know if you can see that well enough. But this is the testicle here, and then the rest of this is actually bowel. Now, when we see that, this is really important. Is it reducible? Well, you're probably not going to be pushing to find out, but reducible means does it go back in? So if it's fat, let's say you have a patient who's not a little child, and you say, okay, push down. And they push down, and it goes all the way out. And then they relax, and then the hernia goes back in. That's reducible. It's automatically reducing. It's just doctor talk. Strangulation is completely different. If it is non-reducible and the blood supply is cut off, that is an emergency. So if it is reducible, it probably will not become strangulated. If it is not reducible, then it has a greater chance of becoming strangulated. But just kind of make sure you got the different terms there. And this would be like a typical exam. Cover them right there, and then this is where your transducer goes. Up a little bit, down a little bit, and you try to see what's going on. On this picture, we actually see, let's look at this. So it's a transverse image. Here we have muscle down here, spine. So if that's the spine, this has got to be the psoas muscle here. Okay, I can't read that either. I'm looking at right here. Yeah, no. So I guess what we're looking at is just a little bit of tissue popping through. So we're right on the edge of the pelvic cavity, and we have a little bit of tissue. It's hard to see that in transverse. Now, if you saw it live, it'd be obvious. Here is a nice image. The normal, you guys can see this. The peritoneal cavity is coming along right there. You can kind of see. You can see where there's a little bit of peritoneum there, and a little peritoneum there, and perhaps all the way up to, oops. Anyway, this is a decent size. I don't know how zoomed in they are, but that's a decent size rip in the cavity here. And so all of this, when this patient is valsalving, it comes out. And then when they relax, you'll actually see it go back in this case, because I'm sure this one's reducible. It clearly looks like a reducible type. And so if you could turn in a cine loop, awesome. If you could have the doctor come in and witness it for themselves, awesome. Or if you don't have cine loop capabilities, or in my case, one of the last hospitals, my machine could do it, but the PACS system couldn't. Just take picture as it's going back out and then in, and then the doctor just literally just rolls through pictures quickly and kind of makes his or her own movie out of it. Whoops, that's wrong. Since I already mentioned we already mentioned hematoma and hematoceles, we'll just quickly go over this, and then in piocele, I literally just mentioned piocele because it's basically the same thing, and then we're done. So keep you a little bit longer. I wrote it hematoma versus hematocele. They're really not that different. Hematoma is going to be more encapsulated, like a hematoma inside the skin or inside the testicle, whereas a hematocele is bleeding in between. By the way, notice how on this hematocele, testicle is attached to the bottom of the scrotum there. So let's see, hematoma, testicular, extratesticular, or scrotal wall. So that hematoma could be here. This looks like it's scrotal wall here. And yeah, because there's a line in between. And once it's in between this area, whether we call it a hematoma or hematocele, it starts to get a little bit tricky. Certainly if it's very liquidy, like fresh blood, then it's hematocele. So a hematocele could be trauma, tumor, surgery, torsion. How would torsion cause I guess torsion would have to cause bleeding, because hematocele, we are talking, of course, by blood, right? Blood in vaginal, it's a tunica vaginalis space, but I'm just going to put space. And then really quickly for a piocele, not shown, I didn't grab any pictures because basically a piocele looks a lot like this. It's going to be, a piocele is pus, and it's similar loculated heterogeneous view. But on this one, boy, you can see this testicle back here. And all of this heavy loculations in blood that is starting to coagulate. So this person probably had some kind of trauma. Usually this doesn't just happen. Oh, damn. All right. Well, the good news is tomorrow, guys, once we get to this side, I kind of zoom through this quickly. So tomorrow might actually be a short day unless well, maybe we'll do some review. But it is 3 o'clock. All right, I did tell that story before. All right, well. Okay. I think we're cool, guys. Already losing some of you. John Paul, we're going to pick on you, have you stick around. All right, guys, we'll see you tomorrow. Unless there's anything last minute. No? Okay. See you tomorrow.
So we don't have any homework today?
I couldn't get to it. Sorry.